HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Associate Professor Jeremy Grummet on prostate cancer screening. Associate Professor Grummet, tell us about yourself.
Thanks, David, and thanks for having me on this episode. I'm a urologist at the Alfred Hospital in Melbourne, associate professor with Monash University, so practicing urologist, but also do quite a lot of research and education in the area, especially of prostate cancer diagnostics. And I'm actually currently on the committee for updating the prostate cancer testing, so PSA testing guidelines in Australia.
Today, we're going to look at many questions that have been given to you, actually, by GPs who were audiences in various meetings. And so to the listeners, if these podcasts seems to be jumping from many questions, please understand that we are responding to specific questions. So the first question to you, Jeremy. My patient was told by a doctor that duodart may cause cancer. Any thoughts?
Yeah, it's a good question. It's a tricky one because there were some conflicting results from previous studies. So on the one hand, there seemed to be less low-risk prostate cancer in patients who are on duodart, but more high-risk cancer patients, which is obviously caused a bit of a worry. I should just point out that duodart's obviously a trade name, and there is also another similar name, which is doublets. But both of them contain dutasteride, and that's a prostate shrinking medication. There was, however, a recent long-term study that showed no difference in prostate cancer mortality between patients who were taking dutasteride and those who weren't. But what they found actually was that the patients who were taking more of this drug had more PSA testing and biopsies. So it may be that in earlier studies where there was perhaps a slightly higher rate of high-risk cancer, that the increased level of testing was what revealed that. And that might be the case because when patients take a prostate shrinking medication like dutasteride, their PSA is supposed to drop. In fact, it's supposed to drop by half when shrinking the gland. But if it doesn't drop, then that certainly rings alarm bells, and it's a bit of a red flag that in addition to benign enlargement, there might also be cancer present. So we certainly don't use dutasteride for chemo prevention of prostate cancer, but equally, we don't avoid it for the treatment of urinary symptoms for a large benign prostate.
Thank you for that. Second question. What's the utility of PSA in monitoring for relapse of metastatic prostate cancer where the treatment had been deemed successful at suppressing growth, but prostatectomy had not been performed? This particular GP knows that it's not a screening question as such, but it sounds to him or her, the oncology team is using PSA as a screening test for relapse in this patient and in this context, since he is not on active treatment.
Yeah, so this scenario sounds like the patient's on hormone therapy for prostate cancer because it's treatment for metastatic prostate cancer, and hormone therapy is certainly the mainstay. And there are novel hormonal therapy agents as well as chemotherapy, but hormone therapy remains the mainstay. Now, PSA is actually usually very useful in this setting because we use it as a marker for disease control or progression. So if a patient is started on hormone therapy, we do expect a big drop in the PSA, which would indicate some success in terms of control. But if and when the PSA does start to rise, despite a patient being on hormone therapy, then we know that the hormone therapy is losing its effect. And we call that castrate-resistant prostate cancer.
The third question seems to be one that many of us grapple with. How important is above the mean but less than 3 PSA level mean?
This is a great question because I mean it's such obviously such a common scenario, isn't it? So I think we have to remember that PSA level is a continuous variable. Obviously the level of 3 is a cutoff, but it's an arbitrary cutoff in a sense, really just to help us optimize, when more invasive testing for prostate cancer is necessary or not. But when we think of PSA, therefore, as being continuous, it applies, therefore, to whether a PSA is above the mean as well. So in other words, the higher the PSA, regardless of the level, the higher the risk of significant prostate cancer. We just feel that if it gets above 3, the risk is high enough to warrant further testing. So if patients do have a PSA that's above the median PSA, but less than 3, unless there are other risk factors like positive family history of prostate cancer or a nodule on rectal exam, then it is safe to continue to be observed with PSA levels, generally speaking. And I suppose just to add to that, because I think this is really important concept, and I did mention this in the lectures as well, but just to recap because of its importance, is this idea of PSA density. It's a very helpful metric that we're using much more now. And what it is PSA level per unit volume of the prostate gland. So when PSA density is high, such as 20%, 25% or greater, then we know that there's a high risk of significant prostate cancer being present, significant meaning clinically significant, not indolent disease. And the reverse is also true. So in other words, when PSA density is low, we know that there's a much lower risk of prostate cancer being present. Now, just to briefly explain why that is the case, because it is intuitive, but it sometimes needs a bit of an explainer. So when the prostate is enlarged with benign enlargement, so BPH, it produces more PSA. So you get an elevated PSA in that setting. So big prostate, slightly elevated PSA will give you a low PSA density. So that's far more likely to be due to BPH alone. Having said that, it is important to remember that prostate cancer can occur at the same time as BPH. So just to be aware of that. But when the prostate is small and the PSA is high, so there's no sign of BPH, that gives a high PSA density. That's when it's far more likely to be due to cancer. And this is really important also in the context of prostate MRI, which is now a standard part of the workup. When the MRI shows no cancer, but the PSA density is high, that'll occasionally be because there is actually a cancer there, but you can't see it. Now, this is not common, and it's not really an issue for GPs to have to worry about. It's very much within the remit of us as urologists, but really just to have an awareness of that.
Thank you. That's actually really helpful. Now, of course, this next question is also linked to the previous one because it's looking at the rate of rise of the PSA and its link with prostate cancer.
Yeah, and I think there's less enthusiasm for PSA velocity, as we would call it now, as distinct for PSA density. The data is not as robust. So what I would say to this one is that we know that PSA rises faster in general in prostate cancer than it does in BPH, but cutoffs that we used to talk about, like 0.75 nanograms per mil per year, are not actually that helpful. I mean, we see a lot of natural variation in PSA, even within the same person. Even a week apart, you might get more than that with 2 PSAs. So I think PSA velocity is less useful. If a PSA is elevated, that is above 3, then the next step is to repeat it in 1 to 3 months.
Fifth question. Are we to routinely check PSA for men over the age of 50 every 2 years in general practice?
Well, if you home in on the wording of this question, it's this is the big controversy, especially when you say routinely. So I would answer this by saying if a patient wants PSA testing, after a discussion of pros and cons with the GP, then yes, the guidelines as they are at the moment, and they are outdated, as I mentioned before, we're updating them currently with a view to providing much more up-to-date guidelines next year. But the ones that are in place recommend PSA testing every 2 years for patients between 50 and 70 years of age, if they want PSA testing. That's assuming that each of the results are within the normal range. The question, I suppose, is, whether this should be routinely recommended, and that's one of the things we'll be looking at.
Just as a sneak preview of the new guidelines, Jeremy, do you think that might change?
To be honest, it's far too early in the process to make a comment on that. What I can tell you is that there's a lot of activity in Europe at the moment heading towards more national PSA screening programs. And the main reason for that is that there's been a huge risk mitigation in prostate cancer testing over the last few years. And I'm very happy to perhaps summarize some of those risk mitigation factors perhaps towards the end of this talk.
Looking forward to that. Now, will you do random sampling via transperineal biopsy for patients who are MRI contraindicated, or is there another form of imaging modality, for example, PET scans?
This is a really good question. So, we know that it's not that uncommon for MRI to be contraindicated, for patients who have had, for example, a pacemaker, or they might have bilateral total hip replacement, where we know that basically any tissue between the prostheses in bilateral hips on an MRI, you just won't see it because of artifact. So there are, a few indications, and some patients might have claustrophobia as well, which prevents them from having an MRI. So it's a great question. And the answer is you can do either. In other words, you can just go straight to biopsy, which is what we always used to do before MRI of the prostate existed. But PSMA PET is very specific and sensitive for prostate cancer, and it's just a scan, so it's less invasive. So we would normally recommend that as plan B if you can't do an MRI. And we also know that PSMA PET's accuracy for detecting significant cancer is roughly equivalent to MRI. And then if a patient undergoes a PSMA PET in this circumstance and it's negative, well, then we can just keep an eye on that patient and perhaps repeat a PSA in about 6 months' time. But if it's positive, well, then just as if the patient had had a positive MRI, the next step would be to do a biopsy, which would include targeted samples from the visible lesion. But just worth noting that PSMA PET is not actually reimbursed in this particular setting. We usually use it for staging of prostate cancer once you've already got a tissue diagnosis on biopsy that confirms prostate cancer. So in other words, it's used for staging to see if there's any sign of metastatic disease.
Any rough idea what the cost might be?
Probably between $600 and $800.
Right. And that's from any imaging radiology department?
Well, no, because they do have to have specific equipment in order to do PSMA PET. So there are some smaller radiology offices, for example, that won't be able to provide that. So, but usually the radiology offices will, on their website or whatever, they'll tell you what services they provide.
Let's move to question 7. We have a healthy man, 70 years of age. Should he or should he not have PSA testing?
So, as I mentioned before, if patients are thinking about PSA testing, the current or at least the guidelines in place at the moment recommend between ages of 50 and actually specifically 69. Obviously, not a whole lot of difference between 69 and 70, but they're the guidelines. And we all know as clinicians that there's chronological age, the number, and there's biological age of patients. And biological age is obviously far more important, but when you're writing guidelines, you don't have a choice but to use the chronological age. So what it actually comes down to is if a patient is predicted to have a life expectancy of more than a decade, and if they would want to have the option of curative treatment if cancer was found as a result of PSA testing, then the answer is yes. A 70-year-old man should have PSA testing. Now, I've mentioned greater than 10 years. Some guidelines will talk about greater than 7 years, and certainly the written guidelines from 2016 mention that. But actually, the evidence is stronger for patients who have a life expectancy more than 10 years. That's when PSA testing becomes more useful in terms of its potential for reducing mortality in prostate cancer. Remember that even the more aggressive types of prostate cancer are relatively slow growing types of cancers compared to other ones. Just perhaps to add one thing to that, we've got an aging population. And so we've talked about a 70-year-old man, but this question obviously extends into men in their 70s. I mean, I can think of men in my own practice who are, 75 plus, who are out chopping wood every day, and their parents lived into their 90s. I mean, these are the sorts of guys who may benefit, but again, they're individuals rather than populations. And also to remember that we're talking about guidelines, which are not rules. They're guidelines, and we do have to individualize to, the patient who is sitting across from us.
The next question, of course, is quite interesting, because you would think that PSA levels could rise as a reference as we age, but is a PSA level of 3 used as a cutoff across all age groups?
Yeah, it's a good question. There's been a bit of movement in this area. In the past, there were cutoffs that were related to age, but actually the guidelines that are in place at the moment do just talk about a flat rate of PSA of 3 across the ages of for patients who are 50 to 70. Now, as you know, the men in that age group, in addition to being a slowly increasing risk of prostate cancer, will also have the development or the beginnings of BPH. So it does cloud the picture. And that's why, as I mentioned before, PSA density can be quite useful. And, I talked about PSA density being PSA divided by the volume of the prostate. And, it's quite easy to obtain the volume of prostate just with a simple urinary tract ultrasound. It's not overly accurate, but it can give you a decent estimate.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
People with family history, Jeremy, how do you screen them? This doctor had learned a few years ago that a 0.35 rise per year is acceptable. More than that needs to be further investigated. What are the guidelines with or without family history to screen for prostate cancer?
So again, PSA velocity is not something that we're really focusing on, because we don't think the evidence is quite up to scratch. But what I would say is that for patients with a family history of prostate cancer, instead of starting at the age of 50, if a patient has multiple first-degree relatives with prostate cancer, then we suggest starting PSA testing at 40.
Mm-hmm.
Or if they just have one first-degree relative, like brother or father, then from 45. And then again, as long as they're normal, every 2 years from then.
The next question seems to be something you touched on earlier, but it's a slight spin on it. It says, is the upper age limit for PSA likely to change given that men are living longer?
Yeah, so you're right. It's very similar to what we talked about before. And I think the answer is yes. We all know that the population is aging. And given what we talked about, having a life expectancy more than 10 years to make PSA testing useful, then clearly we're going to end up with men who are well into their 70s who may well benefit from PSA. And we don't actually have much in the way of evidence for that just yet, but that's only because there's going to be a lag in terms of timing on that. But that will certainly be the case. Now, having said that, one thing I did want to add is that we know from statistics that have been looked at in Australia that, on the other hand, too many men in their 80s are having PSA tests.
Okay.
So again, the real focus of PSA testing for it to be really the most useful is for men between 50 and 70, generally speaking. Obviously, men in their early 70s is a grey area depending on their comorbidities and their biological age. But once men are getting into their 80s, it becomes much less likely that PSA is going to be useful as a screening test for those men. So based on what we're seeing in Australia at the moment, we're trying to get the message out that, unless a patient has, really significant symptoms, then there's really no need for PSA testing for really elderly men.
Just confirming what you're saying, in an asymptomatic person over the age of 80, there's little utility. But if they're symptomatic,
there might be only to help rule out the possibility of more advanced prostate cancer. We're not going to be looking at curative treatment for men who already, based on their general life expectancy, is less than 10 years. So having said that, if someone's symptomatic, well then of course we want to help them reduce their morbidity from that. And if they're symptomatic because of, for example, locally advanced prostate cancer, then there are obviously very good treatments for that, such as hormone therapy.
Now, next question again is about surveillance. How many patients on active surveillance actually develop metastatic prostate cancer and then misses the chance of curative treatment? I know that all GPs are really afraid of missing these sorts of things.
Absolutely. And so I can tell you, so are we as urologists. So the answer is very, very few, but it's not zero. And I think, if you've been practicing for long enough, we will have all had the rare miss where you've had a patient on active surveillance because all of the parameters appear to be safe, but there has been, some factor that hasn't been recognized, for example, and it's allowed metastasis to occur. But if the patient genuinely has only Gleason 6 disease, which is now called grade group 1, we know that does not metastasize.
Okay.
Now, it might change over time. It might upgrade to a Gleason 7 or higher, and we know that those cancers can sometimes metastasize. But when it's Gleason 6 alone, it can't. And that's why active surveillance is actually the preferred management option. It's not just an option. We do recommend it because the last thing we want to do is overtreat men with low-grade prostate cancer that is actually harmless as it is. So if we subject them to active surveillance or they undergo it, then we can almost always keep a very close eye on their PSA and their low-grade disease. And if there is change and upgrading, well, then we can deal with it at the time. And I think it's important to remember, and we can come back to this at the end again, that diagnostics in prostate cancer have really been revolutionized in the last 5+ years with things like MRI and a safer biopsy technique. So the risks of this occurring, of missing a patient who has been diagnosed with only low-grade disease, are so much lower than they used to be. So just to recap, who are we doing active surveillance for? It is absolutely the grade group 1s or Gleason 6s. And in special circumstances, some men with Gleason 3+4, equaling 7. And when I say 3+4, I mean that the predominant pattern is 3. So that's the less aggressive type of prostate cancer. Some of those men will be eligible or advised that active surveillance is an option. But we don't recommend active surveillance for higher grade prostate cancers because the risk of developing metastases is too high. It's very much at the lower end of the spectrum of disease.
Well, that does give us quite a bit of comfort knowing that you're following up the Gleason 6s and that it's okay to sit on them. In fact, the preferred option.
Yep.
Now, trying to use PSA correctly is also another issue we struggle with. So this question is, if the patient's PSA is greater than 6, will the patient get Medicare rebates for repeating the PSA, say, 1 or 3 months later, because the GP was under the impression that PSA is only rebatable if used once a year?
Well, I have to confess, I had to look this one up myself, having had a look at that question earlier. And interestingly, the rebate conditions have only just changed last month. So this is very topical. So I'm glad that question's on the list. The answer is that if a PSA, and in fact, it doesn't even have to be greater than 6, but just greater than 3, will the patient get a Medicare rebate if it's repeated in 1 to 3 months? The answer is yes, they will. But when you repeat the PSA, it needs to be done in 1 to 3 months. And there are fairly sort of tight stipulations around reimbursement here. So, and this is probably better demonstrated visually than just me talking, but if the PSA is between 2 and 5.5 for patients with a family history of prostate cancer, it'll be reimbursed. If the PSA is between 3 and 5.5 for patients who are simply aged between 50 and 70, a repeat PSA in 1 to 3 months will be reimbursed. Or finally, if the PSA is greater than 5.5 but less than 10 for patients who are older than 70, a repeat PSA in 1 to 3 months will be reimbursed. Now, I should point out that this 1 to 3 months aspect is important because it's clinically relevant. The idea is that it minimizes unnecessary further testing because so often a follow-up PSA has dropped back down to normal. I talked about that variability in individual PSAs earlier. I'm sure everyone's seen it. So it means that if the follow-up PSA has returned to normal, then no further investigation is required at that time. All right. And the other aspect is that it also means that if the subsequent PSA remains elevated, then that patient is also eligible for reimbursement by Medicare with an MRI if it's been ordered by the urologist.
You know, it's actually really important that you told us about this change because it's so recent. All right, moving on to the next question. What management or follow-up is recommended for men with PSA within the normal range, but above the median for the age group?
So again, it would be a PSA every 2 years. At least that's what guidelines would recommend. But, you know, as you would know from just clinical practice, there are a lot of men who may not be satisfied with that. If they're a little bit worried about their own health, and they might want more frequent testing for peace of mind. We all see a handful of those, I'm sure. So for those men, I would suggest just an annual PSA. But bear in mind that it actually will no longer be covered by Medicare if it's less than 2 years between.
Okay. Gotcha. All right, here's an interesting question for you. Why was a transrectal biopsy ever done instead of the transperineal from the get-go? I mean, is it technically easier?
Yes, so I'm glad this question got asked. This has been an area of research that I've personally been involved in for about a decade now, and I'll try not to go on too long because it's an area of my interest. But the answer is yes. Transrectal biopsy is technically easier. You can do it very quickly. You can do it under local anesthetic quickly and easily, you know, in your office. You don't have to necessarily have it done in hospital and so on. So transrectal biopsy was very, I guess, physician-facing or hospital-facing, you might say, because it enabled pretty rapid throughput. Now, the problem is that when you pass a biopsy needle through the rectal wall into the normally sterile prostate, you can introduce rectal bacteria directly into the bloodstream. The prostate's very vascular, and so it's pretty easy for those bugs to access the bloodstream. And of course, that leads to septicemia. So we did some pretty large studies looking at the population prevalence of that, and we found that it was nearly 2% of the time that we did trus biopsies, a patient would become septic. I mean, 1 in 50 men was, to me, just not acceptable. So we had the availability of transperineal biopsy, so biopsy via the perineal skin at the Alfred Hospital, because it was being used for brachytherapy as a treatment for prostate cancer, but we could also use it to pass biopsy needles. And we just noticed that we were getting no infections at all. And so we then prospectively looked forward to see if what the case was, and we ended up having a consecutive series of about 1,200 men undergoing transperineal biopsies, and none of them got septic. So we published variously on this, and many other groups have done the same. So as a result, transperineal biopsy has now become the standard of care because of that risk mitigation in sepsis. And it makes sense. The skin's very easy to disinfect. The other bonus actually is that you don't need to use a big gun prophylactic antibiotic, which we were using for transrectal biopsy. So in addition to improving individual patient safety, you're also improving public health by not using antibiotics unnecessarily.
And of course, these days, when we are so concerned about your bowel microbiota, you certainly don't want to keep changing that too rapidly.
Absolutely. Yep. And that's right. So nowadays, we would either just give a single shot of a first-generation cephalosporin just as a prophylactic for skin commensals, or nothing. So yeah, there's multiple studies now out showing that transperineal biopsy is safe without any prophylactic antibiotics. So big difference, much better for patients.
Great step forward. Thank you. Next questions with regards to the MRI. What is actually recommended for detecting prostate cancer? Just a plain MRI, or do you need a particular contrast?
Yeah, great question. So currently, multi-parametric MRI, which includes contrast, is the recommended option. And that's the option that's reimbursed by Medicare. If it's just a reminder, it does need to be ordered by a specialist in order to get that reimbursement. But there is more evidence coming out to support not having to use contrast, so what we would call biparametric MRI. And that'll be interesting, I think, over the next few years, because if we do move to MRIs without contrast, it would certainly make much more widespread screening for prostate cancer far more feasible, because it takes about 15 minutes instead of the current MRI actually takes up to 45 minutes. So it's a very long scan, and it would obviously make it much more cost effective as well. So it's a bit of a watch this space. But right now, the guidelines at least would tell us to order a multi-parametric MRI.
Whilst we are watching that space, Jeremy, the next space to watch is, of course, artificial intelligence. So the question is, how far are we from using AI for reporting the MRI of prostate results?
Very good question. Well, I think the answer is probably not dissimilar for AI, really across the board in radiology. Although the only thing I would say is perhaps that prostate MRI would have to be one of the more complex types of imaging to read correctly. At the moment, there is already, computer-assisted reporting. So there are pieces of software that radiologists use to help them. But in terms of full AI reporting, that's not happening right now. But who knows? It might be only a small number of years away before AI is actually doing the reading and reporting of the prostate MRI, and then a human just ticks a box to verify it rather than the other way around.
I think the next question may even explain itself, because it asks for, I guess the question really is about excess and costs. But here we go. Why don't we do MRI screening rather than PSA?
So yeah, it's a great question. And there have been some recent studies that looked at this. I think the answer is that it probably relates to some variability in MRI reporting. I just mentioned that prostate MRI is a complex and nuanced scan to read, and radiologists really do require proper training and experience to read them accurately. The other aspect is just the logistical aspect, that the sheer lack of access to MRI machines generally. So you can imagine if the numbers went through the roof in terms of screening men for prostate cancer with MRIs, you would need a lot more machines and a lot more access. So it's interesting though, in terms of PSA or prostate cancer screening generally, if it does happen in the future, and as I said before, there's a lot of talk in Europe about this at the moment, then it would be as a PSA/MRI screening pathway. So as we do for case finding now, if there's an elevated PSA, the patient will go on to have an MRI, and that's how a screening program would work. But it would, at this stage, certainly, it would be initially based on a PSA blood test, because it's cheaper and from a logistic point of view, a whole lot easier.
Now we have a patient question, but it's probably covered earlier, but here we go. For a patient with a PSA of greater than 3.0, If a repeat test after 1 to 3 months shows that it is less than 3, do we repeat the screening again in 2 years or earlier?
Well, what it means is that the higher, earlier level is basically the one that you can ignore. And so it is, generally speaking, and obviously you can't individualize for one patient, but generally speaking, it would be reasonable to repeat screening again in 2 years' time. Now, again, if there's a bit of anxiety, either from the patient or their GP, then you could say, well, let's do it annually for peace of mind. But if we're going to try and be evidence-based, then every 2 years would be reasonable.
Jeremy, what are some comments you might have about risk mitigation in the diagnosis of prostate cancer?
Yeah, so look, I think what's been really exciting for me working in this space and for so many of my colleagues and of course for patients is the changes that have occurred over the last, let's say, 6 to 8 years in prostate cancer diagnostics. It's just been massive. And just to briefly set the scene, that, let's say 8 years ago or more, if a man had an elevated PSA, the next step would be a transrectal biopsy. And that would be without knowing if cancer was present, without knowing if it was present, without knowing where in the prostate it might be. And so, we've already talked about the infection risk, but it also meant that there was a lot of diagnostic inaccuracy. So we moved on an enormous amount from those days now. I mentioned MRI. That's been an absolute game changer. And the reason for that is that if you now get an elevated PSA, as I mentioned, you repeat it, still elevated, the next step after that's an MRI. And it's an excellent triaging test for whether a patient even needs a biopsy. So if the MRI is negative, almost always you can then avoid a biopsy. The caveat to that was what I mentioned before about the patient having a high PSA density or some other significant risk factor. But if those other risk factors are absent, no biopsy needed. So that's been a huge plus. It's meant that about 30% less men would undergo a biopsy in studies that have been performed. So that's a huge drop in unnecessary biopsies. But the other advantage of MRI is that if it's positive, when you do go and do a biopsy, you can absolutely nail the lesion and knowing you've hit it, and because you've targeted on the biopsy. And because when we do a biopsy in real time, we just use an ultrasound. An ultrasound, usually you can't see where the cancer is. The MRI, you can. And so when you do that biopsy, you can target it and be confident that you've got a much more accurate picture of what is actually going on in that prostate. So that's been a huge advantage. The other aspect I've already mentioned, so I won't belabor it, but that is the switch from transrectal to transperineal biopsy. So effectively almost eradicating sepsis from the biopsy procedure itself. So that's been a huge risk mitigation. And the other one that we've seen, and again, we've already mentioned this, is active surveillance. So in the old days, far too many men who had low-grade prostate cancer were getting curative treatment, but they didn't need any treatment. And so that was over-treatment. And of course, you'll all be familiar with what those curative treatments are. They're either radical prostatectomy or radiotherapy to the whole prostate, and they can cause significant side effects, erectile dysfunction, incontinence. If it's radiotherapy, it can cause rectal symptoms, real impacts on men's quality of life. And what that meant was that, unfortunately, a lot of the time we were causing more harm than benefit. That is negated or mitigated enormously by instead having such patients on active surveillance. And as I mentioned, these are the grade group 1 cancers or a small proportion of small Gleason 7s, where it's Gleason pattern 3+4. So they've been 3 enormous factors just over the last several years that have really mitigated the risk involved in PSA testing in the first place. And I suppose I would just add to that one fairly hopeful light on the horizon for further risk mitigation. We don't have long-term oncological outcome proof at this point, but I've got to say that it is looking promising, and that's a treatment option called focal therapy. And that's where we just treat the cancer in the prostate, not the whole prostate gland. It's exactly the same oncological principle as breast cancer, where if it's caught early enough and it's a small lesion, then rather than a radical mastectomy, the standard of care would be a lumpectomy. Now, we don't surgically remove a small piece of prostate cancer just due to the anatomical challenge, but we can certainly ablate that cancer using various forms of energy, whether it's radiotherapy or HIFU or cryotherapy or irreversible electroporation. There are multiple different modalities that can be used to destroy prostate cancer. There's a lot of work being done on that at the moment. And again, if it bears out that we can get, good cancer outcomes and just treat the cancer, then what that means is that the side effects of the treatment will be far, far lower than what we currently accept with the radical curative treatments. Now, it's only going to ever be for a subset of prostate cancer patients. And as I said, it has to be a relatively small tumor. And ideally, it's likely to be the intermediate risk type of cancer that this is going to be appropriate for. But again, this is somewhat speculative at the moment, but we are doing prospective studies, both here in Australia, but also around the world. So that's really exciting, because I think one of the things that's really hard for us to observe as clinicians, and particularly as urologists, is, the side effects that our treatment causes patients. And if we can do whatever we can to minimize them, but not sacrifice cancer cure or control, then that'll be another massive step forward.
Jeremy, thank you for taking us along the ride to see how much has changed in this particular field, not just for our patients, especially for you now in terms of not just the diagnosis, but also the treatment. And I look forward to learning more about focal therapy when you get the data. Thank you for the answers to all those questions. They have been incredibly helpful. I wonder whether or not you might have a parting key message for the GP listeners.
Look, I suppose it would just be to be aware that so much has changed in the last several years. We're not just cruising along at the same level. There's been enormous risk mitigation, and there are likely to be further risk mitigations, not just in diagnostics, but in the actual treatment, as you say, as well. And so I think that should be the context for which we make decisions about PSA testing in future.
Thank you so much, Jeremy.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.